Okay, if I could ask a favor of those in attendance, before you take your seats, maybe step out into the hallway and shoo some of our other colleagues back in. We're going to reconvene in just a minute or two. Everyone, please take your seats. Okay, so everyone, because of that unscheduled break, we're going to go ahead and reconvene now. We're going to consider that our scheduled 15-minute morning break that was supposed to take place at 10. We're going to go ahead and resume and finish the session on challenges for new surgery chairs. We thank our panelists again for their patience and for yours as well. And then instead of our taking our break at 10:15, we'll go directly into the laws lecture with Dr. Pugh. So we'll formally resume the session. If everyone could please take their seats.
Okay, the biggest threat to finishing this session is to see whether or not they can warm up the room and turn off the fire alarms and evacuate the building. Okay, so let's go back to the future. What do you see as the biggest threats to academic surgery and the biggest threats to the field of surgery?
I think I started answering that question. I've reflected a little bit on that. I mean, if you look back, way back, you see that a lot of surgeons were leading significant scientific changes in healthcare and in medicine. My biggest worry has been the changing landscape of healthcare. Now we have systems that are buying hospitals, including academic hospitals, and now introducing things that were foreign concepts to big academic institutions. So for me, I think the biggest challenge will be how do we continue to maintain significant academic pursuit, research, which I think is critical and which I think had distinguished surgery in the past. If you look at great discoveries in medicine, a lot of them were led by surgeons. And there's a lot that has been written on being a surgeon scientist. I think we really need to rethink that and see how we continue to push that and continue to encourage that. For me, that is the biggest threat. I think there has to be a very intentional way to push that, regardless of the noise, which are societal pressures and which are other pressures, and with a focus on the product in the end, the product being the surgeon and how we train our residents and how we train our fellows and what we want as the future of surgery. Yeah.
So I think for academics, the biggest threat is our margins are shrinking, sort of this recognition that taking surgeons out of the operating room and having them do other things is really expensive compared to medical doctors. And so, as Val said, right, the surgeon scientist, and how do we protect that? One of the things that is central to my mission at UNC is trying to bring the missions closer together. So figuring out ways to integrate research and education more into the ways that we deliver care, such that it's a market differentiator and a way to, again, rather than having these silos of do you have protected time, much more how do we weave academics into the care that we provide to patients. The second biggest threat, I think, is to both academics and to surgery as a whole, is sort of this diminishing reimbursement and this sort of clinging to the RVU model of reimbursement for physicians. Because at the end of the day, very few people are covering their salaries now with their RVU productivity. And it's really the downstream revenue for the hospital that needs to be taken into account. And so until we figure out how to integrate our models better and change the ways that we have our compensation plan set up, I think that's going to continue to be a challenge. And as we push surgeons more into the OR and we keep salaries lower for academics, it's like, well, why would somebody stay in academics? And I think we have to really be thoughtful about what it is that we offer within academics that leads to increased career satisfaction. And then I guess the last thing I'll say is, the staffing shortages, the decreasing reimbursement, the systems challenges that we're facing. I think we really need to be disruptive in thinking about the ways that we deliver care. And I'm worried that we're approaching this kind of with incremental changes. And I think that the healthcare system right now is in such peril that we really need to be thinking very creatively about redesigning the ways that we deliver care.
That is, that's a challenge, right? Because we need to figure out how we're going to be 5-10 years ago, and things are changing so rapidly. And I don't think that we can predict exactly where we're going to be. I think the driver of that's going to be economics and informatics, and economics is squeezing everything that we can do. Yeah, I think it's going to be the informatics and the democratization of information that's really going to change things. And have you thought at all, not necessarily using your chair of Department of Surgery hat, but being responsible for a huge organization of surgeons, what that might look like in terms of surgical practice in the future? It is, Caprice, I know that you're thinking about how that might impact evaluation of surgical outcome and how conduct in the operating room is going to do that. But how about just in general? How is the kind of explosion of information systems and machine learning techniques, and how is that going to change how we practice surgery in the future? Not necessarily in the context of a department, but being at the head of a large organization of surgeons, how is that going to impact on all of us?
Yeah. I made this comment yesterday, I think, during my talk that, we've spent most of the last few decades figuring out how to collect data. And I think as we move forward, the next few decades are going to be figuring out how to use data in a more efficient, more effective way. And I think some of that's going to be through machine learning and some of the advances in terms of how data is processed. But I think some of it is also going to be in thinking more broadly than individual institutions in the ways that we deliver care. So how do we share data across larger populations, whether it's your health system, whether it's your state, and use that to identify standards of care in a way that we haven't traditionally. So I think there's going to be increased standardization. I think there's going to be increased processes and pathways that we use in order to try to really streamline some of the waste in our system. The other thing that I think is going to play a huge role is going to be telehealth, and thinking about how do we create opportunities for distance consults, for distance care, and how do we
left the station. So we have to be very nimble. We have to be very flexible. We have to be very open to new things. And but again, for me, it's always as we change along the way, the primary focus should be what kind of outcomes do we want? We shouldn't change just because we want to change, right? We should be we should be very nimble and very strategic in changing and improving efficiency, meanwhile still maintaining quality. If we lose quality in the end and change just because we want to change, then we've lost. And that has happened a lot in the last several decades, where there's a whole lot of societal pressure, there's a whole lot of systemic changes, and nobody really cares about the product in the end. And all these policymakers, you really ask them, will this change lead to a better outcome? And the answer is always, I don't know. So how would you make such great systemic changes without being so sure of the outcome? Why do you want to change something that will not lead to a better outcome? So again, we need to continue to change, but we've got to make sure that the product in the end is actually better than what we have right now.
So let's go and talk a little bit about surgical education of our residents. Is residency training too long? Does it really take 10, 11 years to turn out a pediatric surgeon? Do they all have to do research and then do years of training onto general surgery? Is the new training paradigm for, plastics, cardiac, vascular to do an integrated residency and go directly into vascular cardiac? How does a medical student figure out that they want to do cardiac surgery before they've even been on any surgery?
That's like 50 questions in one. So,
We'll save the easy ones for you.
Let's take one.
yeah, so one that I'm going to take again, I'm going to talk more broadly again, because I'm actually putting a talk together on the changing landscape of surgical education, which I think, again, I'm going to talk about societal pressures, how we went to the 80-hour work week, which I think was a good thing, but nobody thought about the product in the end. Okay, nobody thought about the product. And then every fellowship director starts complaining how the residents were less trained and stuff. We change the medical schools go for, instead of 2 years of basic education, we went to 18 because it was kind of cool and sexy. And everybody went to that. In the end, we have our 4th-year medical students who are sitting for 6 to 8 months, 6 months at least, without doing anything. And so again, all these pressures that everybody's changing and nobody is thinking about the product in the end. Okay, I'm all for change, but the goal should be that we're training people who are equally competent than people who trained 20 years ago. Recognizing that these are different learners, they learn differently and they look at things differently. But I still, having said that, I'm actually still very optimistic, very optimistic about the future of surgery. I think that the younger medical students, if you were at ASC last week or so, it was so wonderful to see all these medical students and undergrads and like trying to do their first presentation and also excited about the future. That gives you a lot of hope. And I think it's still, I think the surgical training of medical students and residents and shaping the future is really important if we actually concentrate on what the product should be and less the process.
So, we took what used to be 100 hours and tried to compress it into 80 hours. And in the old days, I think you put a bunch of smart people in and they just stayed there forever and everybody learned by osmosis. And that's not happening anymore. And I think we're really doing a disservice to our trainees. So I think it's really exciting to see what's happening within the field of surgical education over the last decade or so. I think we're starting to take a more scientific approach to it. I think the first and second trials are great examples of how we can take a scientific approach to trying to figure out how we can improve and design the ways that we take care of patients. I think we need to find ways to carve out more intentional time for people to be teachers. I think it's something that we've always just expected people to do. And as we've talked about, we have different financial and throughput pressures now that make it very challenging for people, even when they want to be teachers, to be able to spend the time that they need to spend. And so how do we find financial ways to carve out the time that people need in order to be intentional about the ways that we educate? The final thing is thinking about how we use technology. And as I talked about yesterday, I'm a big fan of video, but I think there's lots of different ways as video becomes more common in the operating room that we're going to see very intentional ways that we can design systems that allow for us to accelerate the learning curve, to really understand where people are on the learning curve, to help give feedback that's much more specific and much more actionable, and having ways that we have adjuncts to intraoperative teaching and our traditional teaching paradigms.
Good. I think we have some time for questions from the floor. Does anyone have any questions? This is has been a great exercise, not only for new chairs, but really for leadership in different kinds of organizations, especially in the transition between coming into a new situation where you're either a section chair or a division chair, head of a committee, head of an operating room. All these pointers and all these experiences are extremely relevant. Are any questions? Dr. Green?
Wendy Green, Emory Surgery. When you were talking about the future of surgery, and you were just on the cusp of kind of telling us what that would look like, if you could design the system that you think would be the most optimum to be able to provide get the product that we want to have, which is a safe, effective, efficient care that's provided to our patients, that's equitably distributed and provided to all. How would you do that?
That's a really good question. So I think Dr. Greenberg actually mentioned that we should approach this in a scientific way. Okay, we should approach this not driven by the process, but driven by the outcome. And what does that mean? So as we're working on the process, the goal should actually be what we want to come out of that process. Now, that process might actually involve using, again, recognizing, first of all, that these are different learners, okay? We can't use the same old paradigm to train surgeons today than what we did 30 years ago. So it's completely different. These are different learners. We recognize that. We use more technology, recognize that. We don't have to spend 100 hours in the hospital and be more efficient in balancing that. We recognize that. The fact that for example, plastic surgery might or cardiothoracic surgery might require their residents to spend a year or so with general surgery, and those residents spend that year doing scut work or being on the floor and not operating. It's a waste of time, and so maybe be intentional about fixing that. But more importantly, that product should be the same product as Dr. Upchurch, who was a good surgeon, who trained in some time back and had quality. And that is the biggest fear, that we might end up losing that. If we're not focusing on the product, we're focusing so much on the process. And I can say that because of all I've sat in some of these policy meetings where the pressure, and I keep saying, what about the product? What about the product? And everybody's just this pressure from outside, like, this is what everybody's doing right now. And nobody's really thinking about what that product would be. So sitting in those rooms, if anybody has a chance, always bring up, what about the product? What kind of surgeons do we want to train? And less this process of like, oh, now we can't do this because the society is pushing, but we know better, right? Again, doing that in a scientific way. And actually, with all the studies that are being done, the first trial, the second trial, which has shown all of this. But again, just focusing on the product.
So I'm going to take a slightly different approach, and I've been trying to think of the saying, and I'm not going to get it right, but it's basically something along the lines of every system gets the output, the exact output that it's designed to get, right? And I think we all know that the system that we have does not lead to the outcomes that we want it to lead to in terms of efficiency and effectiveness. And so if I could design the future of surgery, what I would want is systems engineers, human factors engineers, organizational psychologists coming in and helping us to really design our system to be more efficient and more effective, right? The fact that we can go online and schedule and reserve a table through OpenTable or get Uber, but we don't have dynamic scheduling for our operating rooms or our clinics is kind of absurd. And so I think that there are many ways in which we are all so overworked and just trying to churn the patients through the system right now that we don't have the space to take a step back and think about how we have to really redesign the system and integrate technology into what we're doing. And so I think there is tremendous opportunity to learn from other disciplines and other domains and how we can deliver better care.
I have that it's about 10:14, 10:15. Brian, do we need to quit now?
Thank you, everybody, for a great session, Val and Caprice. Again, this is a great leadership seminar, not just for rising chairs, but for any new situation. So lessons here are generalizable to a lot of different situations. So thank you very much. Thank you very much for participating.
Thank you.
Fantastic. Thanks to all our panelists. That was outstanding. So we're